We're breaking this masterclass into 5 quick steps: classification, a management summary, key clinical pearls, classic exam traps, and we'll wrap it all up with a quick recall test.
So, let's jump right into step 1, classification.
Here's where so many students make their biggest mistake. They think staging is just about how big the tumor is, right? Well, not here. The BCLC is a combined staging and treatment allocation system. You've got to remember the rule of 3. This entire framework hinges fundamentally on tumor burden, liver function, and the patient's performance status. If you ignore liver function or performance status on an exam question, you're going to get the answer wrong. Let's look at how these 3 variables actually interact across the stages.
Starting off with stage 0, which is the very early stage, I want you to picture the absolute ideal clinical scenario here. We're looking for a tiny single tumor, 2 centimeters or less. Crucially, they have perfectly preserved liver function and a performance status of 0, meaning they're completely asymptomatic and active. Because we're attaching this so early, our treatments are aggressive and curative. We're talking resection, ablation, or even transplantation for highly selected patients.
Let's move to stage A, or the early stage, and see how this builds. The criteria expand just a little bit here. Now you can have a single tumor of any size, or up to 3 small nodules, as long as each one is 3 centimeters or less. Notice that the liver function is still preserved, and the performance status remains a perfect 0. The treatment philosophy? It's essentially the same as stage 0. We're still gunning for a cure with resection in patients with suitable anatomy, ablation, or a liver transplant if they fit the strict criteria.
Okay, now stage B is the intermediate stage, and this is exactly where the exam questions start to get sneaky. Stage B is characterized mainly by multinodular disease, but pay attention to what it does not have. There is absolutely no major vascular invasion and no extra hepatic spread. The liver function is still hanging on and preserved, and the performance status is still 0. But we've crossed a major threshold here. We are stepping away from curative surgery and shifting into local regional treatments, like transarterial chemoembolization or TACE.
Stage C marks the advanced stage. This is a massive turning point. How do you know you're looking at stage C? You're going to see portal vein invasion, or extrahepatic spread, metastases. On top of that, the patient's performance status usually takes a hit, dipping to a 1 or a 2. They are really starting to feel the effects of the disease. However, importantly, their liver function is still preserved just enough to tolerate systemic treatment.
And finally, stage D is the terminal stage. Notice what's missing from these criteria. Tumor size. Stage D is defined strictly by end-stage liver function or a poor performance status, totally regardless of the tumor's physical size. At this point, the patient is simply too frail or their liver is too damaged to tolerate anything other than the absolute best supportive and palliative care.
Let's move into section 2, our management summary.
Look, knowing the stage is only half the battle. Knowing what to actually do with it is how you pass the boards. The overarching pathway of treatment follows this really classic logical progression flowing right down the clinical cascade. We start with curative interventions for the earliest stages. As the disease progresses, we step down to local regional options, then down again to systemic therapy, and finally, we land at supportive care. It's a beautifully logical step-down approach based entirely on that triad of tumor, liver, and performance status.
This table brilliantly illustrates your exam blueprint. Notice how it neatly links our early stages, 0 and A, to curative intent, surgery, ablation, or transplant. Then stage B locks directly onto TACE. Stage C locks onto systemic therapy, and stage D equals supportive and palliative care. If you can just burn this treatment matrix into your mind's eye during your exam, you are going to be unstoppable.
All right, on to section 3, key clinical pearls. To really dominate your boards and dodge those tricky multi-step vignette questions, you need some expert insights. Crucially, do not forget our rule of 3 from the very beginning. A massive, terrifying-looking tumor on a CT scan does not automatically mean terminal stage D. If that patient still has preserved liver function and a good performance status, they might actually be stage A or B depending on the specifics. Do not let tumor size blind you to the other 2 pillars of the BCLC system.
Also keep in mind that liver transplantation is a highly valid curative treatment for selected early hepatocellular carcinoma, but it's definitely not a free-for-all. The patient has to meet strict, accepted guidelines, most commonly the Milan criteria. Exam questions love to test whether you know that a transplant is actually on the table for early disease.
Next up, section 4, classic exam traps.
Examiners absolutely love to test the boundaries of this system. So let's navigate the classic traps they're going to set for you on test day. Trap number 1 is jumping the gun on treatment. The false assumption is that once a patient hits intermediate stage B with multinodular disease, they need immediate systemic therapy. Nope. The reality is that intermediate stage B disease typically requires TACE, transarterial chemoembolization. Save the systemic therapy for stage C.
Trap number 2 is missing the massive significance of portal vein invasion. If a vignette even casually mentions portal vein invasion, literal alarm bells should be ringing in your head. That single finding immediately bumps the patient into the advanced stage C category, completely altering their treatment path, away from curative or local regional therapies, straight over to systemic options.
And trap 3 is assuming stage D is just about physical tumor size. We touched on this a minute ago, but it really bears repeating because it's tested so frequently. The reality is that stage D reflects terminal disease, driven primarily by poor performance status or severely failing liver function. A tiny tumor in a patient with end-stage cirrhosis and poor functional status, that's still stage D.
Let's wrap this up with Section 5, a quick recall test.
All right, let's lock in everything we've just built in this explainer with a rapid recall vignette. This is exactly the kind of synthesis you're going to need to do on the wards and in the exam hall. Consider this presentation. We've got a patient presenting with multifocal HCC, they have preserved liver function, there is zero vascular invasion, and no extrahepatic metastases. Furthermore, they have a good performance status. Take a second, synthesize the triad, the tumor burden, the liver function, and the performance status, and lock in your answer for the BCLC stage and the typical treatment.
Okay, if you said BCLC stage B, the intermediate stage, and chose TACE as the typical treatment, you nailed it. You properly identified that multifocal disease without vascular invasion combined with good liver and physical function places them squarely in stage B. But as you take this framework away from this explainer and onto the actual surgical wards, I want you to ask yourself this. How might a patient's sudden, unexpected drop in performance status, say from an infection, radically flip this entire treatment algorithm overnight? Keep that in the back of your mind, and you'll always be one step ahead.